Hi everyone, welcome to MedGoTo. This is going to be a continuation of our USMLE series. We started with cellular adaptation, and under cellular adaptation, we've already discussed hypertrophy along with hyperplasia. I want to encourage us, if you have not watched the video on the first part of the cellular adaptation, I would strongly encourage that you should watch the video so that can give you a better understanding of the rest of the cellular adaptation that we're going to cover in this video. So the third type of cellular adaptation that I'm going to talk about is metaplasia. And what is metaplasia? This is reversible. It's a reversible replacement of one differentiated cell type by another cell type due to stress, right? Remember, unlike hypertrophy, there's increase in size. Hypoplasia is increase in number of cells, but metaplasia is basically we are replacing one cell by another, right? The name of this, the name of the metaplasia normally goes by the new cell that is there, right? The new replacement. So that would be the name of the metaplasia. So for instance, if the original cell that was there, let's say for instance, it's like maybe squamous. I'm just doing an example. Let's say it's a squamous cell, right? And this squamous cell now become columnar, right? So then the name is going to be columnar metaplasia because that's important for us to remember when we're dealing with those questions. So let's now look at some example of metaplasia. So example of metaplasia. The first example we are going to look at is squamous to glandular. So initial cell there was squamous, now we have glandular. So a classic example of that is Barrett's esophagus. Barrett esophagus. So when we look at this diagram, right? So here we have so going to be the esophagus, right? And there's going to be the stomach, right? And then normally, right, inside the stomach, we normally have acid in the stomach, right? That's been produced by the parietal cells, right? And so the stomach the pH there is always low because of the acid, right? And then in between the esophagus and the stomach, there's a sphincter there, right? That separates both of them. And that sphincter normally prevents the reflux of acid into the esophagus, right? Because the epithelia that's inside the esophagus is not designed to protect against acid, right? So in the esophagus, we have the it's lined by non-keratinized squamous epithelia, whereby the stomach, right, is lined by the glandular cells, right? So in this case, right, if there's a reflux of acid, right, into the esophagus, like in the case of gastroesophageal reflux disease, GERD, right? So if somebody have gastroesophageal reflux disease, whereby because the sphincter is too relaxed, right, and then there is a reflux, constant reflux of acid into the esophagus. So that would change. So the lining of the esophagus has to adapt to the new stress, right? So that would change this lining from non-keratinized squamous cell epithelia, and is going to change it into non-ciliated mucin producing columnar cells. And how do I know that they are mucin? So when you look at the histology, of course, you're going to see those mucin producing cells inside the histology, right? And when this happens, so then we're going to say this is what? This is you can call it glandular metaplasia based on the new name, right? So glandular metaplasia, you can call it columnar metaplasia, right? And when this happens, this is what referred to as Barrett's esophagus, right? And on growth, right? When you look at growth, when you do your endoscopy and you look at the changes in the Barrett in the esophagus, you're going to appear red. We normally call it red verbatim, right? So that's what you're going to see, right? And then when you do your on microscopy, right? On microscopy, you're going to see all these non-ciliated mucin producing columnar cells there, right? And of course, Barrett esophagus, if you don't address Barrett esophagus by preventing the reflux, if the stress continues, this Barrett esophagus can lead to adeno, right? Because now it's glandular. So if the cancer of the glandular develop, it's going to lead to adenocarcinoma of esophagus. So metaplasia is always a risk factor for cancer, right? So that's one example of going from squamous to glandular epithelial, and it's always a broad question that we need to remember. So just a side note, can somebody give me one risk factor for gastroesophageal reflux disease? Obesity, right? So obesity is always a risk factor for it. So moving on. So the next example under metaplasia will be from glandular to glandular. So we are going from glandular epithelia to another glandular epithelium. Example is in the case of H. pylori affecting the stomach, right? So this H. pylori, right, is one of those bacteria that will affect the stomach, right? So, and of course, H. pylori has a lot of virulence factor that normally produce, right? Which we want to talk about when we get to micro, right? And one of them is urease, right? That you can use to convert urea to ammonia, and that can neutralize all those acid in the stomach, right? It will also produce a lot of cytotoxin, which can damage the stomach, right? So it can produce protease and so on and so forth. So all these, right, can place a lot of stress on the stomach, and that can make the epithelia, the glandular epithelia inside the stomach, to change into the one that we normally see in the intestine. So the type of epithelia that we normally see in the intestine, right? Because normally, the way I normally remember them is that in the intestine, it's usually, the pH there is usually more like alkaline, right? Like alkaline, right? Because of the bicarb that's coming from the pancreas, right? As opposed to in the stomach, is acidic. So if H. pylori now is taking over the stomach, and now the acid is being neutralized by those by the action of the H. pylori. So as a result of that, then the pH in the stomach is going to increase, and that to now make the epithelia in the stomach to look like the intestinal epithelia. So this is going to change the glandular epithelia into the intestinal epithelia, right? So which is what we normally refer to as intestinal metaplasia. And how do I know that this is intestinal? So when you look at the histology, right, you're going to see a lot of mucin secreting cells there. So there have to be cells there that are secreting mucus, and that's how you know that this is definitely intestinal metaplasia. So you're going to see all those cells that are producing mucin there. So that's an example of going from glandular to glandular. And that's why with this intestinal metaplasia in the stomach, it can also lead to adenocarcinoma of the stomach. And a couple of, can somebody mention a couple of conditions that are associated with H. pylori, right? Very good, right? So peptic ulcer disease, right? Which could include peptic ulcer disease, which can include gastric ulcer, right? And a duodenal ulcer. What else? Very good, right? Gastritis. Gastritis, so which could be chronic, acute, or chronic, right? And the chronic is usually type D, right? Because type A is usually the autoimmune that is outside with pernicious anemia. What else? Very good, right? So we just mentioned gastric cancer, adenocarcinoma, and of course the last one is mortoma, right? Which is kind of like a lymphoma inside the stomach, right? So these are just some example of condition that are still with H. pylori. Moving on. So another type of metaplasia is when we're going from glandular to squamous, right? So in other words, the original epithelia there was glandular, right? And then because of the stress now, it becomes squamous, right? A classic example is smoking. So when you look at the trachea, of course, the trachea divides into two, right? Into both right and left main stem bronchioles, right? So the bronchioles. So and this bronchus is lined by pseudo stratified columnar epithelium. So it's lined by pseudo stratified columnar epithelium. Right? So if somebody is smoking, so that smoking can place a lot of stress on this epithelia, and it can change it from columnar epithelia, and it can change it into squamous, right? And of course, this can lead to what? This can lead to squamous cell carcinoma, right? Or squamous cell cancer, squamous cell carcinoma of the bronchus, right? And of course, if this is big enough, right, it can block the main stem bronchus, right? And if we block the main stem bronchus, can somebody tell me one complication that could arise as a result of that? Very good, right? So that those patients can develop resorptive atelectasis. So basically, the lung in that area, right, because air is not coming in anymore, right? The lung surrounding will reabsorb. I mean, we take out the air inside the lung. So basically, the lung will place, and that will lead to what we call resorptive what atelectasis as a result of that. So if you see somebody that is having strong long history of smoking, and now came in with maybe progressive shortness of breath, and then when you do your chest X-ray, on your chest X-ray, right, one part of the lung, right? So let's say this is the right lung, this is the left lung. So let's say this area is white out. This is all white, right? Because normally on X-ray, the lung supposed to appear dark, right? So if this is all white out, this area is white out, and at the same time, the trachea deviates to that side. So the trachea deviates to that side. So the reason why trachea deviates to this side is because we've lost volume in this area. So there's a lung collapse in this area. So the trachea deviates to that side. So that tells me that, so that could be one of the differential could be athleticis, secondary to a tumor inside the right mainstem, left mainstem bronchus that's blocking it and thereby causing disruptive of athleticis. The other thing that could also make since we mentioned white out of the X-ray, the other thing that can make the X-ray white out is if there's fluid, right? So if there's fluid in this area, that could also make this area to be white out. But with fluid in this area that makes this area to be white out, that will push the lung to the other side. So the trachea will actually deviate to the opposite side. So that would be a contralateral deviation of the trachea. So that's something that you should be aware of. So anytime one part of the lung is white out on chest X-ray, always ask what's the trachea doing. Is the trachea moving to that side or is it moving to the opposite side? So if the trachea is ipsilateral deviation, think of athleticis. And if it's contralateral deviation, think of pleural effusion on that side, right? So that's smoking. The other one is vaginal pH, right? So when you look at the womb, right? So if you look at the uterus, right? The outer part of the uterus is what we call the cervix, right? And the cervix is divided into two, right? So the one that is inside, which is what we call the endocervix, and the outer part, which is what we call the ectocervix, right? So normally this inner part, the endocervix, right, is usually lined by glandular cells, whereby the ectocervix is lined by squamous, right? So endo, glandular, ecto, squamous, right? So if this endo is exposed to the vaginal pH, right, of course, that will expose this endocervix to a lot of stress, and that will make the glandular epithelium in the endocervix to become squamous, right? So that will make it to become squamous. So the endocervical mucus secreting cell can now become what? Can now become a squamous cell. So moving on to number 4 example. So the 4th example will be from transitional to squamous cell. And the where is location of transitional cell in our body? If you mention urinary system, correct, right? So transitional cell could be in the urinary bladder, it could be in the ureter, right? So it's located in those areas. So if somebody is exposed to things like schistosoma, hematobium. So this schistosoma hematobium, right, can cause irritation inside the bladder. Right? So if you look at the urinary bladder, so it can cause irritation in the lining of the urinary bladder, which is normally transitional cell that normally line the bladder, and that can change that transitional cell into squamous. So then we're going to call this squamous metaplasia. And of course, this also carries the risk of squamous cell carcinoma, right? And just a side note, what's the classic history of bladder cancer on the exam? Classic history of bladder cancer. So you're looking for that patient that have history of significant history of smoking, right? And now present with painless hematuria. So anytime you see somebody with long history of smoking with painless hematuria, always think of bladder cancer, right, on those exams, right? And of course, you want to do your cystoscope, right, to look inside the bladder to look for the tumor. So it's something that we should remember. So history of smoking, painless hematuria, think of bladder cancer. Moving on, the last example under metaplasia is mesenchyma. Metaplasia. So a classic example of this is if somebody have a trauma to the muscle, so somebody will have a trauma to their muscle, and now the muscle now ossify, right? So calcium deposits in the muscle and now become bone. So muscle become bone, right? Which is what we refer to as osseous metaplasia. So we call it osteometaplasia. And this is due to injury. And this has no risk for cancer. So no risk of cancer. Something that we need to remember. So this is an example of metaplasia. So the next one we're going to talk about under our cellular adaptation. I mean, this will be like maladaptation, abnormal adaptation, right? Which is dysplasia. And like we mentioned earlier, right? Metaplasia is a risk factor for dysplasia, right? Hypoplasia is also a risk factor for dysplasia, right? And one of the exceptions that we mentioned to hypoplasia that doesn't lead to dysplasia is what? Anybody remember? Which hypoplasia do we mention earlier that will not lead to it's not a risk factor for cancer? Very good, BPH, right? Remember, we mentioned benign prostatic hyperplasia. So dysplasia, these are disorganized or disordered cellular growth. So basically, that's what they mean. Disordered cellular growth, right? And they're always a potential precursor to cancer. So they can lead to cancer. So anytime you see dysplasia, we have to treat it so that it doesn't lead to us cancer, right? And sometimes when you remove the irritants, right, it could also be reversible. Right? A classic example of is a case of Barrett's esophagus, right? So if somebody has Barrett's esophagus and you do a biopsy and you start to see atypical cells or you start to see dysplasia, is always an indication of eradication. So you need to eradicate it, either by maybe surgery or ablation, right? So you need to do something, right? Same thing too, if you do pap smear, I start seeing all this dysplasia or atypical cells, same thing, you need to do something about it, right? You need to eradicate them because they are always precancerous. If you do eradicate them, that could lead to cancer. So like I mentioned earlier, hypoplasia or metaplasia could be a risk factor for dysplasia. So under microscope, right? So what are the microscopic features of dysplasia? So what do we see under the microscope? Then say, oh yeah, this looks like a dysplastic cells, right? Fancy term, right? So what are the changes? So number, we're looking for changes, right? In the cell size and shape. So the shape will be different, the size will be different, right? And that's what we call, when you see them using the word pleomorphism, that's what basically they mean, right? So when you look at the cell, they are now of different size, right? They are no longer uniform anymore, right? So the shape, the size, everything looks different, right? So that tells us that this is dysplastic cells, right? The other one is tissue orientation, right? So tissue that are initially well arranged, now they are poorly arranged, right? So that's also another feature of dysplasia. And the last one is the nuclear changes that we also see. The nuclear changes, one is increase in nuclear to cytoplasmic ratio. Yes. So normally when you look at the cell, right? So when you look at the cell and you look at the nucleus, right? So when you compare the nucleus, because if this is the nucleus, then this would be cytoplasm, right? So when you compare the nucleus to the cytoplasm should be bigger than the nucleus, right? So when you start having abnormal abnormal growth, right? Because of the excessive growth. So what happens is that there's always a delay in the maturation of the cytoplasm in relative to the nucleus, because the nucleus keep dividing, right? So there has to be a delay in the maturation of the cytoplasm. So as a result of that, what happens is that the cell, the nucleus is now bigger than the cytoplasm. So it looks like something like this. So this is what we mean by increased nuclear to cytoplasmic growth. So it's also another microscopic finding that we can see in dysplasia cell. The other thing we can also see in the nucleus also clumped chromatin. So when you look inside the nucleus, right? So we have the cell, we have the nucleus, so we can see the chromatin. They are normally well arranged inside the nucleus, but if there's rapid growth or abnormal growth, that could make those chromatin to now clump together, right, inside the nucleus. So that's another thing that we see. We also have the way that we normally talks about the severity of dysplasia, right? The severity of dysplasia. So when you see the pathologist, when they look at the slide, they can tell you how severe it is, right? Is it mild? Is it mild? Is it moderate? Or is it severe? So what do they mean by that? So mild basically means you only involve one third of the epithelial thickness. So only involve just one third of the epithelial thickness. And then if two-thirds is involved, right, then we call it moderate. And of course, if there's a full epithelial thickness involvement, then we call it what? Severe, right? And of course, severe can progress to what we call carcinoma in situ. So this is when the whole epithelia is full of cancer, but the cancer has not invaded the basement membrane, right? Because if it invades the basement membrane, then it becomes invasive cancer. So carcinoma in situ is just a cancer that is waiting to invade. It's just waiting for the dates to invade the basement membrane. So that's dysplasia. So we're moving on to the next one, which is atrophy. So another form of cellular adaptation, atrophy. So atrophy, what's atrophy? Or some people will call it atrophy, right? So atrophy. So this is decrease in the size and weight of a tissue or organ. So decrease in size and weight of a tissue or organ is what referred to as atrophy. And then what are the mechanisms that are involved in this atrophy? So number one is the loss of tissue, right, or of cells due to increased catabolism. But when we say catabolism from biology, it means increased breakdown, right? So catabolism means breakdown, and anabolism means you're building it up, right? So shrinkage of cells due to increased catabolism of cell organelles, e.g., maybe like mitochondria, right? And reduction. As a result of that, there has to be reduction cytosol. So that's a classic example. And then most of the time, just a side note, right? So most of the time, when there is catabolism of these cells, right, which is one of the mechanisms of atrophy, sometimes we end up right with undigested lipids. right, from what we call lipid peroxidation. We want to talk about lipid peroxidation, and when we get to when we talk about free radical injury. So basically, what lipid peroxidation means is that when you look at the cell, right? Remember, in the cell we have a cell membrane, right? And in the cell membrane, they are made up of phospholipid. Right? So phospholipid. So this phospholipid, sometimes you can add some free radical can react with it. Example like hydroxy free radical, right? It can react with this phospholipid, and that will also initiate like injury to those cells, right? So, and that's what we call lipid peroxidation. So the product of that, right, is what we usually call, it can form some undigested lipid, right, which we can't digest in our body as a result of the lipid peroxidation of the cell membrane, right? And this lipid peroxidation, they are stored as what we call lipofuscin, or sometimes some textbooks we call it residual bodies. And then this lipofuscin or residual body, they're usually in the primary lysosome, and they can actually present in the tissue, and they can stain the tissue as brown. So sometimes you see them calling them brown atrophy. So they stain the tissue as brown. But one thing that is important that I want us to remember about them is when you see them on the exam, they are normal aging findings, right? So something that we need to remember. So they are normal aging findings. So something we should remember. So that's one of the mechanisms of atrophy. Another mechanism of atrophy is apoptosis, right? Which is programmed cell death, which we'll have to talk about later. Third mechanism is decrease in protein synthesis. So there's a decrease in protein synthesis. Example, the case of muscle wasting syndrome in cancer patients, right? And number 4, which is the last one, is increase in protein degradation. Increase in protein degradation, right? A classic system or pathway that we have in our body that we use to break down protein is the ubiquitin proteasome pathway. So anytime you have a protein and a ubiquitin bind to that protein, is usually a signal for that protein to go and be destroyed in the proteasome. So anytime anytime you have a ubiquitinated protein, it's a signal for them to be destroyed in the proteasome. And this system will be affected in a particular condition that they love asking on the exam. Anybody know the condition? Very good. Parkinson's disease, right? Parkinson's disease. So in Parkinson's disease, we see those we see Lewy body, right? Lewy body. Basically, Lewy bodies are basically ubiquitinated neurofilaments that deposit in the brain and destroy the substantia nigra, and that leads to decrease in dopamine production. And as a result of decreased dopamine production, this patient cannot initiate movement, so they become very stiff. They can't initiate movement anymore. So these are the 4 main mechanisms of atrophy. So shrinkage of cell due to increased catabolism of cell organelle, and remember the lipofuscin, right? Remember the mechanism. Remember it's a normal aging findings. Apoptosis, decreased protein synthesis, and an increased protein degradation. So let's talk about some causes of atrophy. So some of the causes of atrophy that we need to know. So number one is decreased hormone stimulation. So if we are expecting a particular hormone to stimulate a particular organ, if it doesn't stimulate that organ will atrophy, right? And a classic example is somebody that have hypopituitarism, right? And as a result of that, as a result of the hypopituitarism, right, all those hormones that are produced from the hypopituitarism, from the pituitary, they are decreased. Example like ACTH, right? Like TSH, right? TSH, FSH, LH, right? So all these hormones will be decreased, and as a result of that, right, the target organ will be affected, right? And if the target organ is affected, if the target organ is not stimulated, then they want to what? Atrophy. So they want to be atrophy of the adrenal gland, atrophy of the thyroid gland, gonad, and so on and so forth. So let's do a case here. So if you have a female, let's say like 35-year-old female, recently delivered a baby, but the delivery was complicated by significant blood loss, right? So the delivery was complicated by postpartum hemorrhage, right? And now the patient is complaining of failure to lactate, so they can't breastfeed the baby. What do you think is the diagnosis? Very good, Sheehan syndrome, right? So Sheehan syndrome. So with Sheehan syndrome, what happens is, so which is also a form of hypopituitarism. So in pregnancy, because of the production of prolactin during pregnancy, right, the pituitary gets bigger. So even though the pituitary is getting bigger, the blood supply does not change, right? And then when they deliver, right, and if they lose significant amount of blood, that could lead to infarction of the pituitary gland, and that can present as hypopituitarism, right? And then one of the common symptoms they usually have first is failure to lactate. So that's Sheehan syndrome. Another example, excuse me, another cause of atrophy is decreased innervation. So if the muscle is not innervated, right, the patient cannot use the muscle, right, and that can lead to atrophy of the muscle. An example of what we see, poliomyelitis, that normally affects the anterior arm, right, which is also called ventral arm, so you can call it anterior arm or ventral arm. Or Guillain-Barré syndrome, right, which is a problem with the Schwann cells leading to demyelination of the peripheral neurons, or ALS, right, amyotrophic lateral sclerosis that affect both upper motor and the lower motor. Moving on, the third one, another example is decrease in blood flow. So if there's a decrease in blood flow to a particular organ, right, eventually, particularly if it's a chronic decreased blood flow, because if it's acute decreased blood flow, that will lead to ischemia, like gangrene right there, right? So that can lead to well gangrene right away, right? So that will lead to severe ischemia. So there is not enough time to atrophy. But if there's a gradual decrease of blood flow to a tissue, like in the case of progressive arteriosclerosis, whereby you have a particular arterioma that's gradually blocking the blood vessel, that can lead to atrophy. So for instance, like cerebral atrophy. The next example under atrophy is decreased nutrients. Right, so if somebody is not getting enough nutrients, like in the case of marasmus, so that also falls under atrophy. And the last one is increased. If there's increased luminal pressure, increased luminal pressure. So if there's increased luminal pressure, that can lead to what we call compressional atrophy. A classic example is if somebody have hydronephrosis. So let's say this is the bladder, right? So let's say this is the bladder, and connected to the bladder is going to be our ureter, right? And of course, the ureter is connected to the pelvis of the kidney, right? And then we have the kidney right here. I'm sorry, my diagram is not that great, but I hope you guys kind of like get the idea. So if somebody have blockage somewhere, right? So let's say there is a blockage on this side, right, at the junction of the ureter and the bladder. So if there's a blockage there, so what happens is that the urine cannot flow down as they want to. So as a result of that, they have to be what we call hydronephrosis. Right? So the ureter will become dilated, and the urine is going to accumulate, and that urine will increase the intraluminal pressure, right? And that can press on the kidney, right? So that is going to be what we call compressional atrophy of the renal cortex and medulla. And that could be a broad question, like somebody who has like some bad BPH, right? So somebody who has a big prostate and is blocking the urethra, and now they have bilateral hydronephrosis, they can also have to the kidney itself. So they have to be compressional atrophy of the renal cortex and the medulla. But what's going to happen to the smooth muscle of the bladder, right? Because there's a smooth muscle there, we're putting a lot of pressure there. That will lead to what? That can lead to atrophy of the detrusor muscle, that's in the bladder. So even though the kidney is atrophied, right, it can still be compressed, but the muscle itself and the bladder itself is going to hypertrophy. And the last example under increased luminal pressure is in the case of cystic fibrosis. Cystic fibrosis. So in cystic fibrosis, what we see there is that their secretion is very thick. So they have very thick secretion. So for instance, inside their pancreas, right? So let's say this is the pancreatic duct. So we have the pancreatic duct. So because the secretion is so thick, those secretions are not flowing very well, right? So as a result of that, they block the lumen of the pancreatic ducts, and that increases the luminal pressure, and of course that will also lead to what? Compressional atrophy. Which explains why these patients can have, they can develop things like chronic pancreatitis because of the repeated inflammation of the pancreas, right? And with the chronic pancreatitis, with the destruction of the pancreas, they could develop type 1 diabetes, right? Because they can't make insulin anymore, right? So they can develop type 1 diabetes, so they might need insulin, right? And of course, if there's no pancreatic enzyme, they can develop malabsorption, right? So they can have malabsorption of fats, right? And of course, they can have ADEC vitamin deficiency, so they can be prone to osteoporosis, right? Osteomalacia, and so on and so forth, right? So that's so we cover atrophy, right? So the last two things I want to quickly talk about before we complete our cellular adaptation story is aplasia. Aplasia. So what's aplasia? So in aplasia, when you look at most of the organs in our body, they all develop from what we call primordial tissue. So this primordial tissue is what gives rise to those organs. So kind of like a precursor, right? So in aplasia, the primordial tissue is actually there, but for no reason, the organ did not develop, right? So primordial tissue is present, the presence of primordial tissue, but no organ development. So that's basically what aplasia is. So it's failure of self-production during embryogenesis, right? So primordial tissue is present, but no organ, right? What's an example of this one? The example is thymic aplasia, right? Can someone tell us where does thymus develop from? Anyone? Very good, right? So the third pharyngeal portion. It comes from the third pharyngeal pouch. And what else also comes from the third pharyngeal pouch apart from the thymus? Very good, you guys are so good, right? Inferior parathyroid gland. So that also comes from there. So in patients who have thymic aplasia, maybe from D. George syndrome, so in those patients, there is failure of third and fourth pharyngeal pouch, right? So as a result of that, they have no thymus and they have no parathyroid because from the fourth pouch, that's where the superior parathyroid comes from. For this patient, they have no thymus and they are not going to have parathyroid gland. So they have no parathyroid hormone. So if there is no parathyroid hormone, they want to have low calcium. So they want to have things like tetany. And if there's no thymus, right, there will be no T cells. And if there's no T cells normally fight against viral fungal infection. So this patient, they also have recurrent viral fungal infection. So newborn, recurrent viral fungal infection, no thymus, having tetany, think of the George syndrome, right? So that's that. Other example of aplasia will also be aplastic anemia, which could be from medication. Example of medication that can cause aplastic anemia, like thyroid medication, right? Like metimazole, chloramphenicol, right? Benzene, right? All those things lead to aplastic anemia. Of course, we're going to cover it when we get to hematology. I love hematology, guys. And another example of aplasia is aplasia cutis congenita. And this is associated with metimazole. So this is basically newborn, right? And in the center of the head of the newborn, right, is the area. There are some area there. There the ear there is missing. There's some missing hair there because of this medication. So that's what they call aplasia cutis congenita. And then the last part of the cellular adaptation is hypoplasia. And what's hypoplasia? So here there's decrease in cell production during embryogenesis, right? So as a result of that, there's a small organ, right? So the primordial tissue is there, but the organ does not develop fully, right? So there's a decrease in cell production during embryogenesis, right? Leading to small organs. So this is basically incomplete organ development, even though the primordial tissue is present. So incomplete organ development. And a classic example is pulmonary hypoplasia in portal sequence. So in patient who have portal sequence, they can develop pulmonary hypoplasia, right? And which is one to kill them because it's the most common cause of death in this patient. So normally, in the utero, when the fetus is in the utero, let's draw a very nice fetus, right? Let's say that's the mouth of the fetus. Please don't mind my diagram. So let's say this is the mouth area, right? And let's say this area, right, is the kidney area. So normally, the fetus normally swallow the amniotic fluid. So here we have the amniotic fluid. Let me write very well so that people can see what I'm writing. So we have the amniotic fluid. So normally, the fetus normally swallow the amniotic fluid, right? And then they can they also pee. So their pee, their urine, is actually part of the amniotic fluid. So their urine is part of the amniotic fluid. So if there's any condition that prevents the fetus from passing urine, that prevents them from urinating, right? So maybe because they have autosomal recessive polycystic kidney disease, right, which could occur in the uterus, whereby they have, when you do ultrasound, you're going to see bilateral kidney enlargement with a lot of cysts in it, right? Or it could be due to posterior urethral valve. So this is when they have like a valve, right, in the posterior wall of the bladder. So this is the bladder, right? So this is the urethra. So there's a valve there. So as a result of that, the urine cannot. So they have urine accumulation inside the bladder. So they have to have bilateral hydronephrosis as a result of that. Right? It could also be due to maybe from placenta insufficiency. So this could also lead to it. So any of these prevent that fetus from making. So if they are making less urine, they have to develop oligohydramnios. So oligohydramnios is going to develop. Right? And if oligohydramnios develop, there's less amniotic fluid for the baby to swallow into their lungs, right? And also there going to be less pushing inside the amniotic fluid, right? So there's less fluid there, there's less pushing for them. So that will lead to compression of their face. So they have to have abnormal, they have to have flat face. Their face is going to be flat, right? Limb abnormality, so they need to compress their limb, right? And of course, the lung is not going to be also, they have to develop pulmonary hypertension. And the most common cause of death in them is pulmonary hypertension. So this comes to the end of cellular adaptation. It has been a journey. Thank you guys for your patience and for listening to me. And don't forget to subscribe to this channel if you have not done so. Share the page with your friends. Let's grow the community so that we can encourage the group to be making more videos as this. And also let's put on the notification bell so that each time we upload video, you can get the notification. Thank you guys again. See you guys in the next video.